Okay, so we are going to start the next session, that is the free paper presentation on glaucoma. For that, I would like to call our chairperson, Dr. Jai Gopal Agarwal, sir. So if you can please come and have your seat. We have Dr. Lalit Kumar Nepalia, sir, as well, and Dr. Udayaditya Mukhopadhyay. Okay. Okay. So I have all the presenters have loaded their presentations in the computers or the systems. I request all the presenters to please come forward and be seated here. We'll have presentations from both the sides. Okay, first from that side and the second presentation. This is the. Okay. So do we have Dr. Apurva Adhikari, the first presenter? Okay, sir, please come.
Good afternoon, everybody. I will present one study that is about nitarsodil, role of nitarsodil in open-angle glaucoma. Study design is, this is a multi-center, prospective, interventional and open label study, that is the medicine given to the patients is known to both the treating doctor and the patients also, reflecting real world practice. Primary open angle glaucoma patients who are on 1 to 3 anti-glaucoma medications with borderline IOP, means 18 to 20, were randomized into 2 groups. All patients were instructed not to stop existing anti-glaucoma medications. Nitarsodil 0.02% eye drops was added to the treatment group and effects were studied till 12 to 14 months of therapy. Purpose. The primary purpose was to study IOP lowering effect of nitarsodil 0.02% in patients with uncontrolled POAG who have a baseline pressure of average 18 to 20 millimeter mercury. Any adverse effect of the drug was a secondary outcome measure. Methods. 60 patients were selected with diagnosed primary open angle glaucoma and baseline IOP between 18 to 20 millimeter mercury with stable visual fields and randomized into 2 groups of 30 patients each. And the patients who are using nitarsodil eye drops, the eye drop vial is labeled with a different color so that can identify. The central corneal thickness was within the normal range, that is 500 to 540 micron. In one group, patients were allowed to continue 1 to 3 anti-glaucoma drugs, the first line being the latanoprost group of drugs and prostaglandin analogs, and in other group, nitarsodil 0.02% eye drop were added. Patients were followed up on 1st, 3rd, 5th, 9th and 13th month of study. IOP was checked by Goldman applanation tonometer in every visit. Visual fields and RNFL OCT were studied at 5th and 13th month and reviewed. Group receiving nitarsudil 0.02% showed lowering of IOP from first month of therapy and maintained till end of study, means 12 to 14 month of study. The mean IOP lowering was between 2 to 4 millimeter mercury in the treatment group. There was no progression in visual fields, mean deviation, and OCT RNFL, average RNFL thickness in the treatment group. In the control group, 10% of patients showed some deterioration in the visual fields and OCT RNFL. Conclusion. Nitarsudil, when added to current anti-glaucoma therapy with borderline IOP 18 to 20 millimeter mercury, showed significant reduction of IOP with stable visual fields and OCT RNFL. The main adverse effect was hyperemia, 50% of cases, which resolved over time. The other remarkable adverse effect was small perilimbal subconjunctival hemorrhage, seen in about 10% patients. A larger patient population with longer follow-up would be more informative. Thank you. Thank you, sir.
Please wait, sir. We can have the questions from the judges.
Sorry.
Yeah.
Sorry, sir.
You agree that it was a very small group you had studied?
Yes, sir.
So how can you recommend for its use to the audience, unless you have a long-term study with some emphatic results?
Because
or you want to say that it's a good beginning?
yeah, I can say, sir, it is a good beginning because after giving 1 to 3 anti-glaucoma drugs, very small percentage of people rather stabilized and advances. So when putting nitarsudil eye drops, I practically saw that there is some arrest. While in the other group, it progressed to 10 to 12%, I can say. So all are aged patients and all are primary open-angle glaucoma patients, and myopia, diabetes, these are excluded from my study.
You studied this molecule alone, or you had compared it with other contemporary molecules?
No, this nitarsudil, and other hand there is prostaglandin analog, betaxolol, and the third brimonidine. These are 1 to 3 anti-glaucoma drugs on one hand, and other hand, with the 1 to 3 drugs, I added nitarsudil. These are 2 groups.
Right. So which you recommend to be more
I
efficient?
recommend that nitarsudil should be added, because one of my patients, 86 years old now, he was on nitarsudil for last 7 years, and he is doing fine. One night also. That
10% cases you have reported subconjunctival hemorrhage.
Yeah.
That is something.
Sir, but that is resolved.
Sometimes the patient would feel alarming.
Yes.
Having subconjunctival hemorrhage makes everyone feel alarmed.
Right.
Unfortunately, if you or me have it,
Right.
we'll also feel equally, worried and anxious about it.
Yes.
So how about those patients?
Yes, sir. But in many cases, not many cases, all cases, I explain to patient when giving the first time the drops. These may be the side effects of the drugs. Like when we use brimonidine, we always explain to patient that there will be hyperemia. So in this case also, always we advise patients, there may be some hemorrhages, but don't worry about that.
You have said that you are using 3 drugs previously.
Yes.
And then what is the criteria when you are adding the nitarsudil?
Sir, actually, all patients, I kept on nitarsudil for 2 to 3 years, like average 2 years. Then when added nitarsudil, just for out of, we can say curiosity and whether it is effective, new molecule nitarsudil miscillated. So,
But what should be the criteria when you are going to add nitarsudil as an additional drug to control?
So when we are not control the progression, so we added and try to see whether any arrest is there of the visual field and
Okay, thank you
RNA.
so much, sir.
Thank you.
Can we have the next speaker,
Thank you.
Dr. Saurav Haral here?
Thank you, sir.
Okay.
Yes. Good evening, everyone. I'm going to present my paper on last dish stand nitazoxanide critical role for advanced glaucoma patient during COVID-19. My co-author were Dr. V.S. Gupta, sir. Glaucoma is the most important cause of irreversible vision loss globally. Conventionally, the initial standard care for the primary open angle glaucoma is medical, with surgical option generally being reserved for the instances where there is a documented structural or functional progress, despite of the adequate IOP control, or there is an inability to control the IOP on medical management. Conventionally, treatment protocol dictating the use of anti-glaucoma medication till maximally tolerated medical therapy before surgical intervention does not apply to the advanced glaucoma stages. However, with the advent of the COVID-19 pandemic, elective surgeries and procedures were halted and indefinitely deferred. In such scenario, there was no option but to resort to alternative strategies, including modified fixed drug combination within the tenets of previously existing maximally tolerated medical therapy. Availability of eye drop nitazoxanide in India was a new arena to opportunity that could harness for lowering IOP via the new pathway. Our study attempted to elicit the use of nitazoxanide in patients of advanced glaucoma on maximally tolerated medical therapy who could not be offered the option of surgery due to global pandemic lockdown. Our objective was role of eye drop nitazoxanide in the patient with advanced glaucoma on maximum tolerated medical therapy who could not be offered surgery due to global pandemic lockdown. The inclusion criteria of patient with POAG having a CDR of 0.9 or a near total cupping on a maximum tolerated medical therapy for at least 4 weeks and yet could not achieve their target IOP. The target IOP was in the early teens, like in 12 mmFG, and on follow-up we did the IOP, perimetry, the BCVA, and the OCT RNFL, and these changes were observed. We found that in 2 weeks, 28 patients achieved the target IOP. Notably, the target was consistently maintained during the 6-month follow-up. Only 2 patients required the medication adjustment to reach the target. Like the pre-treatment IOP was around 18, which was on the 5-drug therapy, and after starting the nitazoxanide at the 2-week, we had achieved the target IOP. Target IOP attained in 2 weeks and was maintained throughout the 6 months period. The disc changes, there were no further disc changes were seen in the field. There was no defined progression in 30 patients. However, mean deviation was found to increase. OCT RNFL also didn't show any statistically significant progression, and conjunctival hyperemia was seen in 4 patients, and it was mild to moderate. So concluding that eye drop nitazoxanide provides a better IOP control and has a high safety profile even as an add-on to already existing inadequate maximally tolerated medical therapy. Thank you.
Thank you, Saurav. Sir, can we have any questions for him from the judges?
Sure.
Yeah, sir, please ask. Go ahead with the questions.
So it was post-COVID area which made you to
Due to the COVID
test this drug.
Yes, sir. No, sir. It was in the second wave. During the second wave, we did the study actually. During the second wave of the COVID. Until that, we had got the drug in Delhi.
So would you level a pre-testing IOP pressure 18 or something like that as an abnormal pressure?
The patients we selected were of advanced glaucoma, so we generally try to keep the pressures in lower teens. So 18 was an inadequate control for those patients.
Then how can you set target pressure the same for each and every patient? Because target pressure is an individual sort of phenomena. You cannot say that this was a target pressure for all the 28 patients.
Yes, sir.
So why did you go for that? What made you to go for that? What were the criteria?
We actually were trying to do is keep it in the lower teens, but for the study purpose, we needed to have a particular point where we should have. We were trying to keep it in a lower teens only, but for the study purpose, we had calculated is at 12. It can't be generalized for all 28 patients. It should have been individual.
And did you check all the parameters?
Yeah, we checked the optic disc changes, the field changes, and the OCT RNFL. Yes, sir.
Okay. So, what is your carry-home message?
This was just an alternative that we tried during the COVID pandemic, and where we couldn't offer. And today also there are a few patients where you can't you give a surgical option, so we can have a last ditch option to add another therapy to the regular.
You have any proposal for going for some long-term studies?
Yes, sir, but right now we would rather prefer a surgical intervention in advanced glaucoma cases. So those were the desperate times where we needed the desperate measures. So long-term study in such case would only be.
Thank you.
Thank you, sir.
Hello.
Thank you,
Did you
doctor.
notice any changes in the cornea?
Okay, just one question.
Any cornea? Did you notice any changes?
Sir, we didn't observe it at that time. At that time, we didn't knew about it. It has an effect on cornea. So, thank you.
Okay, so the next presenter is Dr. Divya Priya. She'll be speaking on a study of bedtime hypertensive medications, antihypertensive medications, and the influence on glaucoma progression.
You're Dr. Divya? Okay.
Good evening, everyone. Today my presentation is about a study on bedtime antihypertensive medication.
Into the mic.
A study on bedtime antihypertensive medication and their influence on glaucoma progression. There are no financial interests or relationships to disclose in the study. Coming to the introduction, glaucoma is a chronic progressive optic neuropathy characterized by retinal ganglion cell death and associated permanent visual field loss. Systemic antihypertensive medication is used to lower high blood pressure, which itself is a risk factor for elevated intraocular pressure and glaucoma. Ocular blood vessels' autoregulatory capacity may be impaired, making tissue sensitive to OPP alterations and potentially damaging tissue ischemia, reperfusion damage. Vascular dysfunction in patients with systemic hypertension and glaucoma prevents the activation of ocular blood flow regulating mechanism, increasing susceptible to POSG. Coming to the aim, to analyze the effect of antihypertensive medication like calcium channel blockers and angiotensin receptor blockers at bedtime on ocular perfusion pressure and severity of primary open angle glaucoma. Objectives: to assess the effect of antihypertensive medications at bedtime on blood pressure, intraocular pressure, and ocular perfusion pressure. Coming to materials and methods, the study type is observational study. Study duration is of 6 months. Sample size is 60 glaucoma patients. Sampling method is a convenient sampling at tertiary care center. Demographic details were collected. The study was in accordance with the ethical committee guidelines. All the patients were informed about the purpose of the study and an informed consent was obtained. Methodology: best corrected visual acuity in logmer format was recorded. IOP by Goldman applanation tonometer. Anterior segment was examined using slit lamp biomicroscopy. Visual fields by Humphrey visual field analyzer. Gonioscopy was done using 4-mirror gonioscopic lens. Blood pressure was recorded in supine position after 5 minutes of rest. Mean ocular perfusion pressure was calculated using formula 2 by 3 into mean arterial pressure minus IOP. Mean arterial pressure is equal to diastolic blood pressure plus 1/3 systolic blood pressure minus diastolic blood pressure. Inclusion criteria: all the patients with POAG who were being treated with anti-glaucoma medication, who had systemic hypertension and using antihypertensive medications for at least 1 year at bedtime. Exclusion criteria: patients who were known hypertensive but not on bedtime antihypertensive medications, patients who were on irregular anti-glaucoma medications, patients who underwent surgical intervention for glaucoma and secondary glaucoma. Coming to data analysis, the data was collected, the collected data was analyzed using Microsoft Excel. Statistical analysis was done using ANOVA test and independent sample t-test. P-value less than 0.05 is taken as statistically significant. Results: intraocular pressure and systolic blood pressure are statistically not significant. Diastolic blood pressure and ocular perfusion pressure are statistically significant. Coming to the discussion, Mosaic et al. Concluded that OPP as an estimate for the real ocular blood flow that includes both SBP and IOP could be used to better predict POAG and also guide the effectiveness of its treatment. Coming to the limitations, circadian influence on blood pressure and IOP can exist, and IOP peak or IOP swings can be overlooked by single reading. Direct measurement of ocular blood flow could result in different outcomes, as here we calculated MOPP theoretically using a formula. Conclusion, the POAG patients who are using bedtime antihypertensive medication have lower OPP when compared to that of controls, but there was not statistical significance in between patients who are using CCBs and ARBs. Antihypertensive medication reduces the blood pressure, thus lowering the perfusion pressure will have detrimental effect on already compromised optic nerve head in glaucoma patients. Thank you.
Madam, what anti-glaucoma drug all these patients were using?
Timolol and brimonidine.
So you know timolol is a beta blocker? It should not be used in hypertensive patients. It's a big contraindication. So how to correlate your study clinical, in reference to clinical application?
Most of
Antihypertensive, people on antihypertensive drugs should not be prescribed timolol. It's a basic, recommendation, isn't it? If your patients were on timolol, then how to correlate your results?
most of them are using brimonidine, sir, but
No, can you tell us the exact number?
in
Number of patient on timolol and number of patient on brimonidine.
in 60 patients, 40 patients are using brimonidine, sir.
And you said some ethical, you had maintained the order by your ethical committee. So what was the protocol suggested by your ethical committee? Which premier institute, the tertiary center you come from?
Eluru Ashram Medical
Sorry?
Eluru Ashram Medical College.
Okay. So what were the recommendations, what were the protocol suggested by the ethical committee to you while undertaking this study? You have mentioned it in your presentation. So what was that? Never mind. Any other questions, sir?
No. Okay, if we don't have any questions, okay, then we
Thank
can
you.
go to the next speaker, Dr. Muskan Gar. Okay, she'll be speaking on the evaluation of cognitive impairment in POAG patients.
You are Dr. Muskan.
Good evening, respected judges and audience. So I'm going to present on a study on evaluation of cognitive impairment in primary open-angle glaucoma patients. So POAG and cognitive impairment may be associated since both are age-related neurodegenerative processes. Glaucoma patients with cognitive impairment are likely to forget their medications, and that could be leading to worsening of their disease. Increase in level of endogenous cortisol found in POAG has also linked to neurodegeneration, as high cortisol level damages hippocampal neurons. Cognitive impairment may be undetected in glaucoma patient and can contribute to the poor quality of life. So our objective were to evaluate the cognitive impairment in patients of primary open-angle glaucoma and to correlate cognitive impairment in glaucoma with retinal nerve fiber layer and ganglion cell thickness, visual field, and endogenous cortisol level. Our study was done at Dr. RP Center for Ophthalmic Sciences with sample size of 70 POAG patients and 70 age and sex match healthy controls. Inclusion criteria were patients of primary open-angle glaucoma with age more than 40 years with best corrected visual acuity better than 6/12 in both eyes, educated up to 5th standard and willing to give informed consent. Patients of PACG, secondary glaucoma, eye disease other than glaucoma that could have affected RNFL and ganglion cell thickness, patients on systemic medication which could affect cognition, patient with diagnosed neurological and psychiatric disease, and patient with chronic systemic disease were excluded from our study. After meeting the inclusion criteria, the patient who did not meet were excluded. Their informed consent were taken, their evaluation was done, their demographic details were taken, their ophthalmology evaluation including best corrected visual acuity, IOP, goinoscopy, slit lamp biomicroscopy, visual fields, RNFL and GCL OCT, blood sample for cortisol level, cognitive evaluation were done and they were evaluated. Tests for cognitive evaluation included Edinburgh Cognitive Examination for comprehensive cognitive evaluation, PGI memory skill test for comprehensive memory domain, Wisconsin card sorting test for and Gonogo task for executive functioning, and trail making test for attention. These were the cognitive tests to test the specific and different domains of the patient, of cognitive evaluation. So our age and gender were comparable between both the groups, and IOP cup disc ratio were higher in cases, and mean deviation and RNFL thickness were lower in cases. In primary open angle glaucoma patient, we found that A score was significantly lower, indicating comprehensive cognitive impairment as compared to control, as we can see in 13 out of 17 parameters also. Also on PGI memory scale test, we found lower scores indicating decreased comprehensive memory as compared to controls in POAG patients. We also found lower executive functioning on Wisconsin card sorting test and Gonogo task in POAG patients. In trail making test A, we found that the time taken to complete the test was significantly more by cases. In TMTB, the time was taken more, but it was not statistically significant. With correlation, we did not find any correlation of retinal nerve fiber layer and ganglion cell layer thickness with our cognitive impairment, but we found that the higher cup disc ratio were associated with more Wisconsin card sorting test error and less number of correct, and lesser mean deviation with more cortisol level, more time taken in Wisconsin card sorting test and TMTA, which all signified correlation of cognitive impairment with visual field and cortisol level. So we found cognitive impairment in primary open angle glaucoma patient and positive correlation of POAG severity to cognitive impairment in terms of visual field and vertical cup disc ratio. However, there was no brain imaging done, and it was a cross-sectional design. So to conclude that, POAG may be associated with a neurodegenerative process and can adversely affect compliance to therapy, performance on visual field, and overall quality of life. Neuromodulation therapies for improving cognitive deficits can be considered. Increased cortisol level may be associated with cognitive impairment in POAG, so lifestyle modification to reduce stress may be considered. Thank you.
I think it's a new concept you have brought out. Clubbed together, we can call it as a forgetfulness, isn't it?
Sir,
in layman term.
In layman
Cognitive reaction is a technical term. So did you go for all these tests yourself, or you took help of neurologist or psychiatrist?
Sir, psychiatrist, like they told, like I have done tests in front of them few.
Into the mic, please.
Sir, these tests were discussed with the psychiatrist. He was under, like he's the co-author of this also. Under his guidance, I have decided this test. He told me that these are the tests to test the different domains of the cognition. There were previous studies regarding the same thing also, but they have just done a screening test or so. Like different domains were not checked earlier of the cognition. So this is in our study, different domains were checked, and that like he only told to check these tests were like good to check those domains.
Did you go for MRI in all these cases?
No, sir. MRI we have not done it as an objective test, like I said, that is the main. Like we are thinking to do objective evaluation in terms of MRI in future. It was just these tests were done, but no objective tests in terms of MRI or EEG or FNIRS were done in our study. So
basically, you want to say that it has been like a screening sort of procedure?
Yes, sir.
Has it been a screening-like procedure? Confined to our OPD only?
No, sir, it was...
because such cases require multi-dimensional approach,
yes,
multi-faculty approach.
Yes, sir. So next step, our next step would be an objective approach also. Like we have seen this, and now we are trying to objective. We will see also that if on those tests also we found some some deficits in brain or neurodegenerative element by the other tests, like you said MRI or EEG or infrared spectroscopy.
Thank you, ma'am.
Thank you, sir.
Sorry.
Yes, sir.
There are many patients, particularly younger generations, they have a high plasma cortisol level, but without any cognitive disorder. So how can you correlate with those patients if it's a steroid-induced glaucoma or other things?
Sir, but ours is not young. Like the patients which were taken were more than 40 years. They were not like in the younger. Like.
you know that the cognitive impairment also associated with age.
Yes, sir. So that's why
How do you separate that thing?
Sir, that's why age match controls were taken. Like the same age patients the controls we took, they had the same age. Like they were age and sex match control were taken, and that's why we are saying that it is not age based only. There is age based.
Thank you, ma'am.
Thank you, sir.
Okay, thank you, Dr. Muskan. So the next speaker is Dr. Soubhik Borua. Is he present? Dr. Soubhik, I think he's absent. Okay, so the next speaker is Dr. Archana. Archana. We don't have Dr. Archana also. Okay. So next, Dr. Amrita.
So we mark Dr. Borua absent?
Yes, sir. Dr. Borua is absent and
N.
Yeah, he is N, and also Dr. Archana is also absent. I think. Yeah. You're Dr. Amrita, right?
Yes.
Okay. So we have Dr. Amrita. She'll be speaking on neovascular membrane causing blockage of earlier functioning trabeculectomy system.
Good evening, everyone. So my paper is on a descriptive case study of a neovascular membrane causing blockage of earlier functioning trabeculectomy stoma. So neovascular glaucoma, as we all know, is an inflammatory glaucoma characterized by neovascularization of the anterior segment secondary to retinal ischemia. It is a fulminant disease, requires urgent intervention. Surgical intervention in the form of trabeculectomy with mitomycin C or implantation of glaucoma drainage devices may be required for the control of IOP. So, a 63-year-old male patient presented with the complaints of left eye diminution of vision since 7 months. It was gradual in onset, painless and progressive. He gave a history of undergoing cataract surgery in his left eye 7 months ago. The patient was on nil topical medications and was a known diabetic. Coming to the examination part, BCVA for both eye in logma was 0.2. Left eye showed a IOP spike, a high IOP of 38 mmHg at presentation. Anterior segment in left eye showed fine NVI or neovascularization of iris. On gonioscopy, open angles were seen with neovascularization in the nasal angle. The optic disc findings were healthy in both the eyes, vertical CDR being 0.04:1. The fundus findings in the right eye was of non-proliferative diabetic retinopathy changes. Left eye showed vitreous hemorrhage inferiorly and proliferative diabetic retinopathy changes. So my diagnosis in the right eye was NPDR with age-related cataract. In left eye, it was a pseudophakic eye with PDR and neovascular glaucoma. Management 3 sitting of pan-retinal photocoagulation was done in both the eyes. Left eye was started on topical timolol and brimonidine fixed-dose combination, eye drop dorzolamide and oral acetazolamide tablets. Left eye also underwent intravitreal anti-VEGF injection of ranibizumab, followed by trabeculectomy with mitomycin C under local anesthesia. And it achieved a IOP of 12 mmHg with good diffuse filtering bleb. There was resolution of NVI, the rubeosis, 6 weeks postoperatively. The patient was followed up 3 monthly and was found to be stable. Now this is a slit lamp photo. The first photo in inferior gaze was postoperative 4 week and showed a good superior diffusing bleb. And the second photo showed a resolution of NVI. 9 months after the surgery, the patient presented with the complaints of heaviness in left eye. There was NVI noted. IOP was again noted to be 26 mmHg. On gonioscopy, there was a fine lacy membrane of neovessels covering the trap stoma noted. Immediately, fill-in PRP was done in the left eye, followed by anti-VEGF injection. Left eye was taken up for bleb needling in the operating room. Entry was made in the AC beneath the scleral flap with a 30 cc needle to disrupt the neovascular membrane. On 4 weeks follow-up post-needling, the membrane showed complete resolution and there was revival of the filtering bleb. IOP then noted was 10 mmHg. So the first is the gonioscopy photo before needling. There were fine neovessels covering the trap stoma seen. The second photo shows resolution of the neovascular membrane after anti-VEGF injection, fill-in PRP and bleb needling. So neovascular glaucoma is a high-risk factor for failure of trabeculectomies. Trabeculectomy failure in these eyes is traditionally managed with the implantation of GDDs. GDDs is a good treatment option, however, carries risk of tube and plate related complications. Therefore, we propose the maximum attempts to be directed towards the functioning of the primary trabeculectomy, so secondary procedures can be avoided. So, neovascular glaucoma that undergoes trabeculectomy need close follow-up to monitor the primary retinal condition as well as the filtration of the bleb. And timely control of ischemia and VGAF load can help in maintaining the IOP control in these eyes. Thank you.
What are the common causes of neovascularization of the angle of the entry chamber, ma'am?
Diabetes, CR post-occlusive disorders such as CRVO.
Other than these two?
Then can be a masquerade syndrome. There can be any tumor that is causing malignant tumor that can cause NVI. Then can be even old retinal detachment. Even very old retinal detachment can also present with NVI. So.
Can it be there post-traumatic also? You never know.
Yes, sir. Yes, sir. Sorry, sir. The time.
Between the anti-VEGF and the trabeculectomy.
Sir, in this case, we had waited for a period of 2 weeks.
2 weeks.
Yes, sir.
Okay.
Thank you.
Thank you, Dr.
Thank you,
Amrita. So the next speaker is Dr. Sunita. Okay, she will be speaking on a case of ocular hypertension provoked by water drinking during uroflowmetry.
Good evening, everyone. Myself, Dr. Sunita. I am presenting a case of ocular hypertension which is provoked by water drinking during a uroflowmetry. We report a case of open-angle pseudophakic patient who developed sudden onset painful diminution of vision in both eyes after drinking 3 liters of water within a short span of 1 hour. Consumption of water bolus has long been associated with rise in intraocular pressures in both open as well as closed-angle patients. It has been thought to supplant the 24-hour IOP monitoring as the rise in the IOP correlates well with the peak diurnal variation in a given patient. A 54-year-old male patient presented to the eye emergency with complaints of pain, watering, sudden onset diminution of vision in both eyes. Patient was a known case of varicocele with mild hydronephrosis and had undergone a uroflowmetry prior to reporting with the above mentioned complaints, for which he was asked to drink at least 2 to 3 liters of water. Patient had undergone right eye phacosurgery with PCIOL implantation 45 days ago, followed by left eye after 15 days in our hospital itself. Since the patient has been a postoperative case, hence patient was under regular follow-up and the IOP was recorded by NCT, was within the normal range in previous all visits. On ocular examination, the best-corrected visual acuity in right eye was 1/60 and left eye was 2/60. Cornea was edematous with epithelial and stromal edema in both the eyes, with normal pupil with sluggishly reacting pupillary reflexes. Circumcorneal congestion was present in both the eyes, and both the eyes were pseudophakic with a deep anterior chamber. The intraocular pressure by NCT was recorded to be 55 in right eye and 52 mm of Hg in left eye. Rest of the adenexa and anterior segment was unremarkable in both the eyes. Patient was given an intravenous mannitol 20%, 150 ml stat bolus over 15 to 20 minutes. Half hour after giving the mannitol, the NCT was repeated and was found to be 34 mm Hg in right eye and 36 mm Hg in left eye. After the IOP reduced, the cornea cleared significantly. Patient had dramatically improved symptomatically with no pain and watering. Patient was sent home after prescribing tablet acetazolamide 250 mg TDS, eye drop timolol, brimonidine, dorzolamide in both the eyes. Patient was advised to follow up the next day in OPD. On subsequent visit, his IOP recorded by NCT was 23 mm Hg in right eye and 22 mm Hg in left eye with absolutely clear corneas. Patient was advised to stop all the medications and review after 1 week for further evaluation. The IOP recorded with Goldman applanation tonometry in next visit was 16 mm Hg in right eye and 14 in the left eye with no further complaints. Gonioscopy was done before dilating the patient for fundus examination, where all the angles were found to be open with no other abnormal findings. On dilated fundus examination, the tropicamide plus phenylephrine, a normal fundus with 0.3 vertical CDR with healthy NRRM was seen. Hazen rule was followed with the normal AV ratio of 2:3. No wedge-shaped defects or splinter hemorrhages were seen around the disc. Foveal reflex was present in both the eyes. OCT RNFL showed normal thickness of retinal nerve fiber layers in all the quadrants, and all the medications were stopped and a review was scheduled after 3 months, and the patient was advised against drinking large bolus of fluids and to review immediately in case of ocular discomfort, pain, or heaviness. Water drinking test was first described as a provocation test for glaucoma in 1960s. However, it was associated with markedly unacceptable false positive and false negative results. In the 1980s, Amelie et al. Found a good correlation between the IOP and the water drinking test, that in the 24 IOP curve. Consequently, the concept about the water drinking test has changed and it is no longer used as a diagnostic test, but rather as a useful tool to assess the IOP peaks. Recently, this test was revived with a new purpose. It has been used as a surrogate marker for the outflow facility reserve and may be an indicator of the likelihood of progression of glaucoma. The mechanism of IOP elevation remains unclear, but there are some postulates such as limited outflow facility, increased episcleral venous pressure, increased IOP mediated by the autonomic nervous system, and the choroidal expansion. Eyes with lower outflow facility should experience higher IOP peaks after ingestion of water than eyes with normal outflow function, thus being a surrogate measure of the outflow system of the eye and its ability to respond to transient IOP elevations. According to the review published by Susanna et al. In 2017, an IOP peak in the water drinking test that exceeds 5 mmHg is associated with 6 times increased risk of new onset of glaucoma. In addition, medically controlled glaucoma patients have a greater IOP increase with the water drinking test than patients who have undergone filtration surgery such as TRAB and deep sclerotomy, despite similar mean IOP at the baseline. This behavior is probably due to the fact that filtering procedures facilitate aqueous humor outflow more effectively than the medical therapy. To conclude, the role of water drinking provocative test as a diagnostic or as a prognostic test still remains debatable. However, those patients that may have to drink water bolus in a short span should be warned of the possible rise in IOP, especially wherein a patient might have to do it repeatedly. And a possible clearance from the ophthalmologist should be sought before putting patient through these tests, like as in uriflowmetry or USG scans in gynec patients or bladder cancer patients before radiation therapy. Most of these patients are elderly and have a higher chance of raised IOP. Post the test, so raised IOP post the test. So a before and after clearance from the ophthalmologist is warranted, at least for the first time the patient is put through such tests. Thank you.
I think it's an eye-opener case, because our urologist friends are getting this test done in virtually all patients of benign hyperplasia of prostate coming to them for problems.
Have you done all the investigation yourself?
Yes, sir.
And have you done it, or your originality is really it is because you have, I think you have taken the text from any part because it has mentioned in that.
Sir, I have given the references for the text that I have taken. For the discussion part only, I have taken the
No, it's all right. One thing.
Yes, sir.
What should be the advice to the patient post-operative?
Post the test. So we keep the patient, we ask the patient if the patient feels, if he can come to the OPD and get his NCT checked, that is the best thing. If not, then he should.
How often?
Sorry?
How often?
How often is not necessary, but then
yes,
it is
necessary.
undergoing.
It's necessary.
It is necessary.
This is a provocative test that can
yes.
induce glaucoma, it's all right. But with the aging process, the trabecular sclerosis will go on. Naturally, this is a test where this patient can develop process to the glaucoma later on. Naturally, you have to keep him under follow-up lifelong.
He is under follow-up. He has been explained.
And another
he
thing,
might undergo the same
this test
again.
game, another thing you have to follow, every primary open-angle glaucoma. Advise them, please, not to drink water so much amount regularly. Yes, you can take 250 ml or like that.
Thank you, ma'am.
Thank you, sir.
Okay, thank you, Dr. Sunita.
Thank you, sir.
So can we have the next speaker, Dr. Parag? Okay, Dr. Parag is absent. So then we move on to Dr. Manpreet. I think she is here and she'll be presenting the sporadic and a rare presentation of anterior segment dysgenesis. Dr. Parag is absent.
Yes.
So you can go ahead.
Mosquitoes are here. Probably.
Good evening, everybody. I'll be presenting a case of anterior segment dysgenesis. So this is a child named Harpreet Singh. He's a 7-year-old male from Punjab. He presented to us in our OPD with a chief complaint, as explained by his guardians, of diminished vision since birth, which was associated with photophobia, but there was no history of any redness, pain or discharge, any kind of nystagmus or squint. The child had a past history of chronic urticaria for which he was taking treatment on antihistaminic drugs. There was no positive family history and the birth history was normal. This is the pedigree chart of the family of the child. No other family member is affected except the boy. On general systemic examination as done by the pediatrician, there were no systemic associations found. The chest was within normal limits. Similarly, the cardiac system, the CNS, there was no microdontia or any facial abnormalities present. On ocular examination of this child, his vision in both the eyes, the presentation was similar. The vision was finger counting 1 meters with accurate PR. Extraocular movements were full, free and painless. His pressures, he was already started on Dorzox T before he had presented to us in the OPD, and on applanation tonometry, his pressures were 20 and 10. The corneal thickness was increased. It was 800 and 700 in right and left eye respectively. Adnexa was within normal limits. The corneal curvature was normal. The diameter of the cornea, it was 9 into 9, which is microcornea. The axial length was high, so it is a microcornea presentation. On slit lamp examination, both the eyes had almost similar presentations. The conjunctiva was in normal limits. In cornea, as you can all see, there are multiple corneal opacifications and the surface was irregular. The anterior chamber was irregular and shallow, and the pupil was eccentric, peaking and non-reacting to light. Iris, there were multiple iridocorneal adhesions and there was no sign of any polychoria, correctopia or iris atrophy, and there was an absorbed cataracceous lens. This is the presentation of his left eye. So we did an ultrasound biomicroscopy. On ultrasound biomicroscopy, we saw broad iris processes which were tenting over the angle and attaching to the corneal endothelium. We further went for an anterior segment OCT, in which the anterior chamber was irregular, shallow, with multiple iridocorneal adhesions, although the corneal layers appear to be normal. The fundus of the child could not be examined as the pupil was just 2 mm in size. It was non-reacting and it was not dilating. So we had to go for an B scan, in which we saw multiple hyperechoic echogenicities in the vitreous with low A scan peaks after movements were present, and it was not diminishing on low gain, which was suggestive of PVD. So the unique characteristics in this case that it is bilateral presentation since birth. There is no associated family history or no associated systemic features. There are multiple iridocorneal adhesions and pupillary abnormality. The pressures are high and it has the child has congenital cataract. As we all know that neural crest cell migrates, and if there is any immature halt in its migration, it leads to Exenfield or Peters anomaly and other kind of congenital anterior segment developmental associations. But this is a rare presentation. It does not fit into Peters or into Exenfield-Rieger syndrome. So to manage this child, the only goal we had that the child should get complete visual improvement. We started him on glaucoma management. Luckily, his pressures are being controlled on medical therapy. He's on Dorzox T. We did a cataract lensectomy with anterior vitrectomy, and further the child will be planned for optical keratoplasty. Thank you.
First thing is we should wish good luck to you and to the child also for the future course of your protocol you have just mentioned. So, I mean, what made you to feel like that this patient is having this particular problem?
Sir,
because there's a difficult, it's a difficult thing to have proper communication with such a small child, and must be having a village background, must be an illiterate child. So how could you make up your mind regarding this diagnosis?
Sir, we've still not reached the diagnosis. That is one of the major problems, that we just know that it is one form of anterior segment dysgenesis, but looking at the review of literature, there is no presentation like this. And even the management with other cases of Peters and other cases of Exenfield, the way they have managed, they have undergone keratoplasties or congenital cataract. For the child of this age, going for such surgeries, the failure rates are also very high. Plus going for, luckily his pressures are managed, but going for TRAB and GDD are something which we have to do in such cases. So we are still stuck at how to further progress, because even with low vision aids, his vision is...
It's very difficult to manage such cases, because whatever maybe you do, even if we at our best, there is a gross amblyopic chance.
Yes, sir.
And the thing is that it's also hard to diagnose, a pinpoint diagnosis. It's better to be under a broad heading of neurocrestopathies.
Yes, sir.
Because all the things develop from there.
Neurocrestopathies.
So still it is diagnosed, better term is a neurocrestopathy. That's all, thank you.
After lensectomy, did you get a chance to view the fundus?
No, sir. It's still not visible. There is a very faint fundal glow, so we are still clueless of how the fundus feels.
Right. Thank you, ma'am.
Thank you, sir.